Okay, so obviously this in-service is on dementia. I kind of just briefly went over all the different types of dementia. Some of them I went a little more in depth with, and I'll kind of explain that to you. I'm Cassie Maish. I work on Maple Lane for anybody who doesn't know me. And for those of you that do know me will understand why I started my first slide out with a joke, because I joke around a lot. So it says, senile dementia is not so bad, Mrs. DuPont. It's kind of like having brand new friends every day. So unfortunately, that's what dementia is like, is it's, you know, starting fresh every, however long the one person specifically it is that their timetable of reset. So basically what happens is when we're born, inside of our brain, we're born with over 100 billion neurons in our brain. But our bodies don't know what to do with it until after time. So each of the neurons, they have different jobs. They form our thoughts, our feelings, all of our memories. And that kind of goes into where I was explaining when you're born, they're just not connected to each other. And as you go and learn things, the message travels from one neuron to the next repetitively. So like tying your shoe. You'll see a little kid learn to tie their shoe, and they can't quite get it, but they get a few parts. And next time they get a little bit better at it and a little bit better, and until they eventually get it. And those neurons have connected and made a pathway to make your brain remember how to do things over and over again. And you become better and better at it. So thinking back to the first time you rode a bike, you have to learn to pedal it, you have to learn to balance it, you have to learn to steer, you have to learn to brake, and maybe at one point or another, you're doing it all at once. So it becomes really hard work for your brain to have to come and think about all those things. And then, later on in life, it happens, dementia. And not necessarily for everybody, but for some people, unfortunately, dementia happens. So, what is dementia? Dementia is actually an umbrella term where all the diseases fall underneath of it. So it's a slow progressive decline in the mental function, including memory and thinking, judgment, and the ability to learn. But like I said, it's an umbrella. So dementia is just grabbing all those terms and pulling it into one thing. And underneath the umbrella, like I handed out to everybody, is each disease itself. Usually it occurs in people older than 65, and I said usually because there are strange cases where someone might have dementia and they're 35, 40. Earlier onset is a specific kind of dementia. It's not always that specific kind, but most times it is a different, a specific kind of dementia. Most conditions that cause dementia, they cannot be reversed. Once you have it, it's a brain issue, and you can't reverse it. Sometimes specific dementias that are caused by things that we do in life, like maybe you had a brain injury, you can kind of halt it a little bit, but you can't stop it. Maybe there's a vascular injury and you're not getting enough blood supply to your brain. You can halt it with medications, but again, the damage that's done is done. You can't undo that damage. It does worsen over time, as we all have seen many times here. And like I said, it's not a disease, but a group of symptoms. Early identification is really important with dementia too. That way you can start to make your plans and your ideas and your actions and have family to help you. Typically, it takes 5 years before recognition, and by that point you're already at mid-stage dementia, which if you're trying to do it on your own, you're financially swamped at that point. You don't have caregivers that are close by unless they're picking up on the signs and symptoms, and so it really makes for a much worse situation. So symptoms of dementia, I'm sure we all can probably list off memory loss, because that's a pretty obvious one. Memory loss is for sure a sign and symptom. They also become disoriented to time and place. So you might pick one person and say, do you know where you are today? They're not going to know. Do you know who you are? They'll know their name. But they probably won't know where they are, what time it is, what day it is, anything like that. A lot of times too, you'll see language problems. They can't form the proper words, they can't say what they want to say, it's frustrating because they can't get it out appropriately. Decreased concentration. They don't stay on task. You can give them a simple command and maybe one or two can complete it, but it's not very often. Changes in personality and mood or behavior, we see that a lot. The frustration is what brings out a lot of the different moods. Difficulty performing daily tasks, well obviously we're helping everybody here, because they can't complete those tasks on their own. Sometimes they might do something simple with you standing there and giving verbal cues over and over and over again, like brush your teeth. You gotta show them, and they can do those things, but they have to follow your command.
Kathy, are those symptoms for people who already, that are at Mako, but not necessarily all of them are going to show somebody who first?
You may not see it right away.
Okay.
And as we get a little deeper into this too, each different type of dementia, so Alzheimer's is a type of dementia, or vascular dementia is a type. Each one has their own symptoms too. This is just like a broad idea of what happens when you see somebody who has dementia. Unfortunately, there's situations too that can cause pseudo-dementias. So it looks like a dementia, but it's not. And those times, typically it's a lot quicker ran through. So like a delirium, for example. It can be caused by dehydration, it can be caused by a hospital stay, a med that they might be disagreeing with. Sometimes they might have a little stroke and then they're kind of starting to recover a little bit, but they do have some of these things. But that doesn't mean necessarily that they have dementia if that's, if you're seeing those things, excuse me. Obviously with the delirium, it's short term, it's acute, it's going to happen, and with time it'll go away. It's not going to be long term like dementia would. Depression is another one of the pseudo dementias that we see. They become withdrawn, they become a person that doesn't want to interact with everything and everybody, and it seems like they have decreased concentration, and it seems like maybe there are changes in personality and mood. But what makes it super complicated in the whole diagnosis process is these 3 Ds like to hang out together. So you will see dementia, delirium, and depression all at once sometimes too. So it really becomes super duper complicated. A recent study showed that people over 65 years of age, they stayed in a hospital because of delirium or with delirium. Actually, within 2 years, 50% of those people had full-blown dementia without even having any signs or symptoms to begin with. And that's because they went undiagnosed for so long. And they have a vulnerable brain, and unfortunately, it got attacked. Okay, so the tangles and plaques, they again are not with every dementia either. Mainly, you're going to see the tangles and plaques with Alzheimer's. That's going to be your main disease that has Alzheimer's, that has the tangles and plaques. And then most people, they develop the plaques and tangles as they grow older, but the person with Alzheimer's is going to have more. And so as you can see on here, these pieces here are being attacked, and this is the plaques, and they're the part that's growing out to cover the surface of the cortex of the brain. The tissues in the brain have fewer nerve cells because they are being attacked by the plaques. They typically cluster and build up between the nerve cells, like I showed you in that slide. And then the dead and dying nerve cells that contain the contain the tangles, with the strands of the protein, that's what's being actually choked and the communication gets blocked off. So, 4 truths about dementia. At least 2 parts of the brain are dying, and one is always related to memory. Not always new info, sometimes it's old too that you're losing. So most of the time it's the hippocampus, it's right at the base of your brain that gets attacked for memory. That's what holds your short-term memory. But it's not always that way. With certain dementias, it's not about remembering, it's about misremembering. So what that means is if I thought I might have dementia because I forgot where my car keys were. That doesn't mean I have dementia. But if I don't know what this is used for, then I probably should start looking into what's going on. Because I'm misremembering why I have a cup and what I'm supposed to do with it, but I just misplaced my keys. So I'm not forgetting in that sense. It's chronic. It can't be fixed like we talked about before. We can fix the situations leading up to it in some circumstances. There's certain medications that you can take to help increase your memory and make the last years dignified, but there's no fix. It's progressive and it gets worse. As the plaques grow or the tangles grow, more things get shut off. And it's terminal and it will kill eventually. All dementias get worse, it's just how they get worse is the question. So then I threw the cat in the hat in here too. I think it's big enough for everybody to be able to read. If you've never heard this before, it's kind of funny. I cannot see, I cannot pee, I cannot chew, I cannot screw. Oh my God, what can I do? My memory shrinks, my hearing stinks. No sense of smell, I look like hell. My mood is bad, can you tell? My body's drooping, have trouble pooping. The golden years have come at last. The golden years can kiss my hay. All right, so going into the types of dementia. You have the umbrella there, and it shows you underneath the umbrella, we have Alzheimer's, and Alzheimer's can have early onset and normal onset. Early onset is anything 65 or younger. Normal onset is 65 or greater. Vascular dementia is the one that's going to shut off brain, blood flow to the brain and kind of deoxygenate your brain. Lewy body, it's a specific kind of dementia that gets misdiagnosed or misdiagnosed. Lots of times it grows tiny little cell portions on your brain, and I've got a slide for that too that show you. Frontal temporal lobe, again, it's going to be up here in your frontal lobe or the temporal lobe that's right here behind your ears. And then the other dementias that can happen, you know, there's dementia because you are an alcoholic, there's Parkinson's, there's depressive issues, and they're all listed there. And then underneath each box below kind of gives you more insight on each individual dementia, but I kind of go into detail with some of them. So Alzheimer's. It's a disease, it's progressive, it gradually destroys the memory, takes away their ability to learn, reason, and make judgments, communicate and carry out daily activities, like bathing and eating, simple stuff. It accounts for 50 to 70% of all dementia cases, so this one is the one that's diagnosed most often. Typically with this one, first symptoms to last symptoms is 8 to 12 years. So if you're diagnosed with Alzheimer's, it's a typical 8 to 12 year span. Okay, so the 4 stages of Alzheimer's, I kind of put a little slide on here to show you the degeneration of the brain. So obviously A goes with early stage, B with the middle stage, C with the late stage, and then of course end of life stage, you probably would have an almost totally blue brain there. And that the blueness in the brain obviously is showing you like the shutting down areas of typical for Alzheimer's. Here's another slide with the brain on it. The severity of the Alzheimer's disease is very, very obvious in this one. You can see the cortex around the outside of the brain has all been shriveled. The cells die, the abilities are lost to complete anything. All your different pockets in there, just obvious atrophy. Your pockets are all much larger in the severe brain versus the healthy brain. The ventricle fluid-filled spaces in the brain also grow larger, and I put little circles around them. The top circle is the shrinkage of the hippocampus, and that's where I was talking, like right in the base back there. That's the one that plays the role in the formation of all your new memories. and then the ventricle spaces that are all opened. And so there's kind of the outside of it and what it looks like, and you can see how the cortex, they're much deeper ridges. The normal brain has the nice tight look to it. And it's also, you can see how much smaller it is too, just from that aerial view. All right, with vascular dementia, it's a decline in thinking skills caused by conditions that block or reduce the blood flow to the brain, not allowing the oxygen and nutrients to come to the brain the proper way. It is the second most common dementia, accounting for 15 to 20% of dementias, right underneath Alzheimer's. And with this one, it's kind of difficult because your first to last in your diagnosis can be 3 to 30 years. So it varies so much. It's unpredictable purely because it's a blood supply problem. With vascular dementia, it presents as a sudden change. So someone might be normal and then a month later we're seeing huge changes in them. Emotions really get affected with this one. It's the emotional control center in your brain is completely out of control. They have bounce back days and bad days. So there's great days, happy, everything seems fine, and then there's horrible days. So the typical person with vascular dementia, they might come up to somebody and be like, "How are you today?" And you ask me,
How are you today?
"I don't know!" And they have no idea how they're doing because the brain isn't allowing them to function their emotions properly. When you reach somebody like that, it sounds harsh and cold, but no matter what comfort you give them, it'll continually get worse. So that kind of person, you just basically have to move on to the next thing. Here's a box of tissues, come on, let's go have a cup of coffee. Because if you sit and try to comfort them, it's going to be one thing after another, and they don't understand why they're feeling the way that they're feeling. This is also the same person that you say, "Come on, let's go take a shower, it's your shower night." No. Well, you get 1 a week or 2 a week. Why don't we just go do that now? Let's go take your shower. No. Okay, well, would you like to take a shower in a little bit? No, I said no, get out of my room. So you leave and then wait for that reset button and come back and reapproach. And reapproaching later sometimes works, sometimes it doesn't. But that's the type of person it is. Also with this person, they can be very apathetic, very flat, that flat effect that they can get. Sitting in front of a TV, and that's all they want to do. Why don't we go do something? No. Do you want to go for a walk with me? No. Okay, well, we should probably eat something. Why don't we go eat? You can bring it to me. That monotone, low-lying behavior. And there's nothing you're going to do for them either, other than letting that reset button go. They'll have spotty losses too with this one, meaning major points of clarity. Sometimes you'll talk to them and you're like, really? For me, in an example, I'll talk to somebody on Maple Lane and I'll be like, gosh, I wonder why they're even here. If I didn't know their background any better. But sometimes you'll walk up to somebody and you don't even know, and then the next time you talk to them, it's completely different. But they have those points of clarity, where sometimes it seems like they're okay. And then the emotional energy shifts like we talked about. Lewy body dementia, this is the one that is the most misdiagnosed, or like I said, misdiagnosed. So rather misdiagnosed meaning it doesn't get diagnosed appropriately, or misdiagnosed, it just doesn't get diagnosed. It's a progressive dementia, leads to decline in thinking, reasoning, independent functions, just like other ones. But this one is the one that leaves the microscopic deposits that damage your brain cells over time. And the next slide shows a good picture of it. So that's basically a slice that they put under a microscope, and you're able to see the deposits on there. Yes.
Are there any tests they do while they're living to look at their brain?
To figure out for Lewy body,
For,
for any of these,
Yep.
you can do like CT scans and those kinds of things just to be able to see like the shrinkage. They also can do tests that'll show color differentials in their brain. I should have put some of those slides up, but it'll show different colors, the warm and the colds. And basically, if it's a cold color that comes up, you know that there's not enough blood supply to that area is dying, those kinds of things. So you're able to see it a lot better on the screen. With Lewy body, this one has problems with movement, and you see fall after fall after fall after fall with these people. They have a really bad shuffle, and they can't get their coordination together appropriately. They will see visual hallucinations. With this one, most common is animal, children, and people. So you might hear somebody say, "Oh, get those kids out of there," and they clearly see the kids. Even though you and I can't see the kids, there's kids there that they see completely. Or animals, "Come on, boy," you know, calling the dog. You might see that. Or petting the dog, you know, and nothing's there. Fine motor problems with their hands and swallowing. These people, not always again, but most times might have swallowing issues and beer thickened liquids and those kinds of people. Just really rigid. They'll have tremors when they're trying to complete things. So trying to grab the cup, you know, might be this versus like a Parkinson's that has the tremors all the time. Nightmares are very common for somebody with Lewy body as well. They'll have the night terrors where they think their dreams are super real. And it's very, very, very scary for them. And then their fluctuation in abilities too. Sometimes they can brush their teeth, sometimes they can't. And sometimes with certain medications that the person may be on, may or may not be on, responses to that can be really strange. Like they might have some sort of abnormal activity that they do because of a medication that they tried. And it may not even be a medication that's related to dementia at all. It could be just, you know, a heart medication and the brain doesn't accept it properly. So the main differences between Alzheimer's and Lewy body: memory loss. Yes, they both have memory loss, but memory loss is different. Alzheimer's, it kind of attacks with the plaques and the tangles, where Lewy body is more spotty, and you have maybe more abilities with Lewy body than with Alzheimer's. Movement and symptoms, that's not necessarily affected in Alzheimer's, more so in Lewy body. The shuffling gait, the falls, you know, the uncoordination, those kinds of things. Excuse me, hallucinations, delusions, those kinds of things are more so Lewy body. The REM sleep disorder, that would be earlier and more extreme in Lewy body than in Alzheimer's. And they do, Lewy body people are also very, very, very daytime sleepy. You'll see them snap all day long and try to stay up all night. Disruption with the gait instability, and it's a typical younger onset in Alzheimer's versus Lewy body. Lewy body's a later one. The frontal temporal lobe dementia. This one I don't have too terribly much on. It's one of the least common out of the big boxes on the top. This one is a group of disorders caused by progressive cell degeneration in the frontal lobes and the area behind your forehead, which is the temporal lobes, or behind your ears. It was once considered very rare to have this. Now makes up about 10 to 15% of all dementia cases. So the red area and the purple area are the two that are typically affected the most in this disease. And when you're looking at Alzheimer's, vascular, and Lewy body, this is by far the least of those. Most often, frontal temporal lobe disease or dementia, you're gonna see in somebody who maybe had brain injury. So I know someone who had part of their frontal lobe removed. She does have a difficult time remembering things. It's hard for her to remember more short-term than long-term. She has had some tests done and they don't believe she has frontal temporal lobe at all, but she is a much younger person and concerned for herself, obviously, because I mean, she's probably more at risk than you or I having that brain injury. The other dementias, the mixed dementia just means that you're having more than one type of dementia at the same time. Parkinson's often is another one that we see. It can be very similar, like it says, to Lewy body or Alzheimer's. Creutzfeldt-Jakob disease, it's kind of, a few years ago we heard all about the mad cow disease, and that's where that one is, where your brain gets affected from that. And then this last one is the one that is most common because of alcohol misuse. It's a deficiency in the B1 vitamin. So then I have some approaches for how to work with people with dementia. These videos are kind of fakey because they're actors, but you'll get the idea of what they're trying to say to you. So when working with someone, I think this one is the entering the room one. Yeah.
Hi, I'm Amy. I was calling as a casual. Sorry I'm late.
Oops, sorry. Oh gosh, I'm gonna mess it up. I have a problem with this.
Hi, I'm Amy. I was called in as a casual. Sorry I'm late. The bus took forever and I wasn't exactly sure where I was going.
That's okay, Amy. I'm Betty. A few of our regular staff are away sick. I really appreciate your coming in to help. You're going to help Mr. Chalmers. He's in room 321. He needs help to get up and dressed.
Okay, is there anything you could tell me about him?
Mr. Chalmers has dementia, and he sometimes gets confused about where he is, but otherwise he's pretty good.
Okay, is there anything else?
Well, you can flip through this if you'd like. It has information on all our residents here.
I see he's really involved in the exercise classes you have going on here.
Mr. Chalmers was quite the athlete in his day. And he does his best to try and stay in shape, but it's very frustrating for him because of his balance and flexibility.
Oh, yeah. Okay, that's great. Thank you.
Always try to learn about the person you are caring for. As a care provider, you have the right to information to help you work safely. Ask the questions and get the answers that may help you better prepare and care for the person. If you are a casual worker, be extra cautious and take extra time. You likely won't have had the opportunity to get to know the person well, and they likely won't know you. The more you know, the safer you will be. Before providing care, always do a self-check first, taking note of your own stress level and emotional state. Your emotions always precede you. People with dementia are often exquisitely tuned to the body language of others. Be aware that you are communicating simply in the way you move and interact. Pause and compose yourself prior to entering a room or home. Go slow, smile, and ask permission.
Mr. Chalmers, it's Amy, one of the staff here. May I come in?
Yeah, okay.
Good morning, Mr. Chalmers. My name is Amy. I'm here to help you get your day started.
Oh,
May I raise your blinds, Mr. Chalmers, so we can let a little more light in here?
yes, okay.
There, now we can see outside.
personal space, their home. They may not know who you are or why you're there. They may even feel that you are trespassing. Be respectful of their space and their personal possessions. Speak slowly and in simple terms. Listen to the person's responses. Try to evaluate how well they are interacting and understanding. Keep in mind that the person may not understand your words, may be using the wrong words, or simply may be unable to communicate. Take your time and look for the common language.
Today is your exercise class, Mr. Chalmers.
Good.
Here. I'll raise the head of the bed a bit to help you sit up.
Do everything you can to maintain the person's dignity. Focus on the person, not on the task. Use personal history to gain their cooperation and trust.
Get out of here! Get out of here! You can't do it! You're not the one! I want Mary back. Go out of here! Leave me
Sorry, I didn't mean
alone!
to frighten you. You want to be left alone. I'll come back later.
Go! Leave me! Leave me alone! Go away!
Sometimes, people with dementia may become aggressive or even violent quite suddenly and without warning. In these situations, caregivers should immediately remove themselves from the environment and allow the person to calm down.
I was just helping him sit up when all of a sudden you tried to hit me.
Really? Okay, well, we'll give him a few minutes and then we'll try again together. Oh, and I'll make a report. In the meantime, can you check on Mrs. Smith? She's in 325. Thank you.
It's important to know when to walk away. Backing off from a bad situation is not neglectful. It's the right and safe thing to do. Always report the incident so that it can be documented and effective care strategies explored. This not only represents good care for the person, but it also helps protect others.
Mrs. Leon? What's wrong? I'm going home. I have to go home. My daughter is waiting. Oh, you mean your daughter Kim? How old is she now? She's just a little one, a baby. That's why she needs me. Oh, that's okay. Kim is safe. I'm sure of that. There's no need to worry. How do you know? Have you seen her? Yeah, I saw her last week.
An important skill to learn when caring for persons with dementia is how to distract them away from unsafe behaviors, such as trying to leave the facility, and how to redirect their focus on another activity. Knowledge of their family and personal history can often be of help when trying to do this. Use probing questions, both to distract the person from what they are attempting to do, and also to try and learn the root cause of the anxiety. Avoid grabbing them or their walker, as this may trigger an aggressive reaction.
How about if we phone your daughter Kim and find out how she's doing? You mean call her now? Yeah, but let's call her from your room. It'll be quieter in there. Okay. Oh, and you have that lovely family photo album. We can look through that.
Always keep validating the person's concerns and feelings while redirecting the conversation and their focus. Keep comments short and simple. Provide the person with choices and tell them what they can do.
And in this picture, which one's Kim? Here. She's in Oh, yes. She's beautiful. Wow. And that's her there too. That's cute.
For a person attempting to go home, never simply say, "This is your home," as this in no way validates the person's concern. And if a resident does leave the building, simply follow them outside and use the same techniques of distraction and redirection.
Just a couple more.
Okay, Sergeant, let's get you out of this bed and into the chair, okay? So Heather and I are going to take this sling and place it behind your back to secure you. Sound good? So if we could have you sit up just for a second, that would be fantastic. Ready? 1, 2, 3. Up you go. Perfect. Great. Now we'll have you lie back down, Sergeant. There you go. Great. Heather, we'll just do 1, 2, 3. Great. And we're going to lift your leg just for a second, Sergeant. Excellent. And now your arms. Thank you. Excellent. Perfect. We're good to go.
You can sometimes do everything right and things will go wrong. That's just the way it goes. The key is how you handle things when they don't go the way you planned or expected.
Okay, Heather, if you got that in. There we go. So we did okay, Sergeant? Okay, so we're just going to hook the sling to the lift right now. First. It was so great to see your family here on the weekend. Everybody looked great. We doing okay? Well, listen, you can help us out by holding on here and we'll secure you, okay? So you hold right there. Is everything okay? Great, we're going to raise the lift now. Okay. Here we go.
Try to explain what you are doing step by step as you do it, and involve the person in the process as much as possible. Use personal information to establish trust and gain their cooperation.
Okay, here we go, Sergeant. It's okay, we're just going to use the lift to raise you now. You're perfectly fine. Excellent. Okay, Heather. Great, here we go, Sergeant. Sergeant, everything's okay. You're perfectly fine. Sergeant, you're okay.
If the person becomes agitated, stop immediately and evaluate. It's not about doing a certain number of bathings or dressings. It's about caring for people, one at a time.
Sergeant, everything's okay. You're perfectly fine. Take a deep breath. Okay, Sergeant, we don't need to do this right now. I'm just going to lower the lift for you, okay? Here we go. The lift's coming down. Just relax, Sergeant. It's okay. Heather, we okay? Great. It's okay. Just breathe, Sergeant. We're just lowering the lift. There we go. There we go. So, Sergeant, we're just going to take these hooks off now. Okay. Excellent. And we're going to take the machine away. So I'm sorry that we upset you. We don't have to do this now. We'll come back a little later, okay? Excellent. Okay, Heather. You just relax, Sergeant.
Good.
If things aren't working, walk away and try later. You may find that the person suffers from pain, may be afraid of the mechanical equipment, may not comprehend the language used, or simply may not want to get out of bed.
He just wasn't himself today.
Yeah, I know.
I mean, he's usually fine with the lifts, so I'm going to let the nurse know and she can decide whether or not he requires a reassessment.
Good idea.
Evaluate the situation and be flexible with how you choose to deal with it. Don't hesitate to ask for support, and don't feel that you have to do things just because of a schedule. And remember to always report back whenever you witness a change in a person's behavior.
Did you have good sleep last night?
It's not too bad.
Yeah? How was your breakfast?
Oh, it's pretty nice. I had eggs.
Did you get all your favorites?
Yes.
Oh, that's wonderful. Okay, Alice, you ready for your bath then?
I don't like the baths.
I know. Here, let me help you out with your sweater, okay?
Oh,
You a little stiff there?
yes.
Okay. Well, why don't we try this other side? Good. Good. Feel better?
Yes.
Good. There we go.
For people with dementia, bathing time can be an especially stressful time. In fact, they can be very resistant to the whole process. As a care aide, you can do a few simple things to make bathing easier, less stressful, and safer for both you and the person. First of all, be organized and efficient. This doesn't mean working fast, it just means knowing the equipment and having everything ready to go once you start. Keep the person as warm and comfortable as possible. Try to avoid associating bath time with pain or discomfort of any kind. And if there's any suggestion of anxiety or panic on the part of the person, just stop and reevaluate. Use personal information to gain cooperation and trust, and as a tool to distract.
You warm enough, Alice?
It's cold.
The bath can help. Okay, I'm gonna fly. Retest the temperature for water, okay? There you go, it's okay. There you go. How's that?
Nice.
It's lovely. You ready to go in? Oh, it's okay. It's okay. Okay? It's okay. It'll be fine.
It's a good idea to let the person test the water themselves. After all, it's their bath. If the person is self-conscious about being exposed, keep them covered with their gown, or use a poncho, towel, or blanket around them to maintain their dignity. And remember that the head and face areas are the most sensitive. Wash the hair last, and be gentle.
You okay?
I'm cold. I'm all done. Just get me out of here.
It's all right, baby. I'm just gonna get warm cloths for you. I'll wash it in front, okay? Exactly, that's great.
Encourage the person to do as much of the work as possible. And, as always, focus on the person, not the task. Tell others what has worked well and report when things aren't going well so that an individualized bathing plan can be developed. By following these simple techniques, you can make bathing a more pleasurable experience for both the person with dementia and the caregiver.
Okay, so those are just some approaches that I found that I thought were relatively interesting. And then this is the last thing I'm gonna close with. It's just a video about this lady, and her husband put it together for her. The first part, there's no voice or sound until about 56 seconds in, and then it's really self-explanatory, but it's sad.
Do you remember the day you were told that you had Alzheimer's? That was at the age of 43, as we mentioned. What went through your mind? How did you handle it?
Well, I have always been a fighter, so I think my personality helped me. And the jobs that I had were difficult jobs, and I did well in those until a certain point.
Well, you lost your mother and your sister to Alzheimer's, and your sister died at 48 of Alzheimer's?
No, she was 49.
What's happening?
In this clip, Chris is realizing something's wrong, but she doesn't know what it is. The shoe is on the wrong foot.
Do you want to get a glass of juice?
Yeah.
Can you pour one? Can you get one?
Like over here?
Yeah, can you get a glass of juice?
Yeah.
Yeah.
Just get it?
Yeah.
Okay.
Yeah.
What's amazing about this disease and the short-term memory loss is Chris can walk away from me and in just a few seconds be surprised that I'm there.
And you are my love.
Huh?
Love
What
it.
did you do?
Later with you.
Yeah.
Do you remember that? Where?
Are you having a good day, sweetie?
Yes, now. Oh my gosh. Oh my gosh, I'm sure.
Hi.
I love you too. Hi, sweetie.
I love you. Are you free today? You ready to switch? There you go. Relax. No. Ready? 1, 2, 3. Good. Hey, look, you did good. Good. Are you doing good? Are you doing good?
Yes.
Ooh, huh? Do I get a hug?
Yes.
Can I have a hug? You gotta give me
sad. That was only between the time that she was walking 10 miles through the facility was a year, and she couldn't even walk without assistance. It's such a tough disease. And then last, I just added this for kind of a pick-me-up after the sad video. It's sort of funny. You guys can read it.